So good morning and a warm welcome to all. At the outset, I'd like to thank Dr. Ramesh, Dr. Arulmari Valman and all my co-speakers, including AIOs, for this wonderful opportunity. So my talk is on phaco in post-keratoplasty. As in any cataract surgery, nothing is over till you remove the clamp and patch the Balen's eye. So this is what exactly I'm going to tell you in this video. So this is a phacoemulsification post lamellar keratoplasty. You could see a 360-degree synechia which is being released here, shown here, and then following a capsulorhexis. It
Sir, we are not
also
seeing those videos, sir.
playing now.
Yes,
Yes.
you can see your
So
video.
this was a routine post-keratoplastic cataract surgery where visco has been injected and the cataract surgery is being performed, and it was a textbook teaching. So the IOL is injected right into the bag without any problem, and the visco has been aspirated and everything goes on well. The wound has been hydrated, and there goes it. And you see the descent membrane has been stripped while closing the side ports. So here comes the intraoperative OCT, where you could see the cleavage between at the graft host junction, where it's closely separated. Luckily, the endothelium has not been stripped completely. So the intraoperative OCT really comes in play here, and now you have to really manage this descent membrane stripping. So you have to inject air into the anterior chamber, make sure that the stripping does not extend, and with the help of a 10-0 nylon, you see that the end of the needle goes right into the descent membrane and doesn't strip it further, and then you can anchor the descent membrane with these 10-0 nylon. So once this is done, you can further inject air into the anterior chamber, and you could see that the graft is completely sealed. So this is what I was trying to say. Nothing is over till the end of the surgery. So as in any other cataract surgery, normally in any other cataract surgery, we decide to plan the surgery only a couple of days before. But in keratoplasty, it is not so. The preoperative assessment has to start at least 3 to 4 months before. Some of the features that has to be taken into account is a stable keratometry, the endothelial count, the corneal clarity, the type and size and location of the graft, all has to be taken into account. You have to have a stable keratometry. If you have done a penetrating keratoplasty, ensure that all the sutures are removed and you have a stable keratometry at least 3 months apart. Take 2 keratometries which are 3 months apart and ensure that they are stable before you plan your cataract surgery. The endothelial count, normally the endothelial count in these patients range somewhere between 700 to 1400, and if it is less, always counsel the patient for a simultaneous DSEC or a DMEC following phacoemulsification, because you would always damage the endothelium when the cell count is low. Look for the corneal clarity and make sure that you're able to perform the cataract surgery well and plan your incision. The type and size of graft is also important in these cases, because you need to plan where you have to place your incision, whether it has to be clear corneal in the host or a sclerocorneal. The other parameters which has to be looked into account are the axial length, the presence of posterior synechia, the nuclear density has to be assessed very importantly, because sometimes we're using higher phaco energy, you can also cause a zonular dialysis. The zonular integrity has to be checked before you go ahead with the cataract surgery. So as I told you earlier, suture removal, stable keratometry with at least 3 months apart, corneal clarity, specular microscopy. The type of keratoplasty is very important because you need to place your incision, the size of the graft and the position of the graft. Biometry, the optical biometry is the gold standard here. However, in denser cataracts, you can go for an immersion biometry. Use 3 mm zone of the corneal topography and don't go for the SIMK reading. Regular astigmatism, you can consider toric IOLs. It is always proved that the average astigmatism in a simultaneous cataract surgery following keratoplasty is around 7 diopters. So the challenge here is to always keep the astigmatism as less as possible. The IOL formula, use the latest generation IOL formulas, and be very careful when you use premium IOLs in these patients. When you have an irregular astigmatism, do not use your toric IOLs, and multifocals, I normally try to keep it apart. Zonular integrity and macular status is also important and has to be kept in place. The post-operative assessment is also important. Control inflammation, use long-term steroids, look for signs of graft rejection, and also control the comorbid conditions. Now let me go into the video. Yes, phaco in keratoplasty. So we have planned the keratoplasty, planned the phacoemulsification, and once we go into the intraoperative steps, always ensure that you have a posterior entry. The entry for any kind of incision in a post keratoplasty should always be as posterior as possible, sometimes even limbal. Make sure you make all the entry only in the host and never in the graft. When you inject fluid into the anterior chamber, always see the tip of the cannula. Make sure you're right into the anterior chamber and then inject it. This is all to prevent the descent stripping, as I showed you in my first video. Always make the entry as posterior as possible. Direct your keratome right in the center of the nucleus. All these cases have a shallow anterior chamber, so it's very important that you keep the anterior chamber always deep by using copious amount of dispersive and coercive viscoelastic. Your aim should always be to protect the endothelium. While doing the rexes, always use the tri-soft shell technique as described by Ashenov, which consists of a dispersive viscoelastic coating the endothelium, a coercive viscoelastic to maintain the anterior chamber, and always do the rexes in the lake of BSS, which you inject beneath the coercive viscoelastic, because you'll find that it's always difficult to move the flap in a shallow anterior chamber in the presence of coercive viscoelastic. The tri-soft shell technique always gives you an additional leverage to do the rexes easily. While doing the hydrodissection, also ensure you always see the tip go in the right plane beneath the capsule and direct the fluid. Never direct it above the capsule into the iris, where it could cause iris fluttering or even damage the endothelium. As I told you earlier, whatever instrument you take it into the anterior chamber, be very careful. Do not strip the corneal endothelium while putting your phaco into the anterior chamber. So this point talks about the entry. This is an eccentric size graft where you don't see the host at all. The graft goes till the limbus. So in these cases, you have to make a scleral corneal tunnel. So the bleeding is also a part of this. So make sure that you make a scleral incision. Going into the phaco techniques, this is the phaco in anterior lamellar thoracic keratoplasties. The main a point to be considered is the surge prevention. These eyes usually have a very shallow anterior chamber. Here comes the latest generation phaco machines, where you can maintain the anterior chamber by playing with your phaco settings. Use your phacometry parameters as low as possible. Use copious amount of dispersive and coercive viscoelastics. In soft cases, it's quite easy. You just do a superficial phacoemulsification and you can aspirate the cortex quite easily, as shown here. While doing your IOL insertion, endothelial damage happens quite often, even in normal cases. So ensure that you enter the anterior chamber and insert the IOL right into the bag. The main aim is to prevent the endothelial damage. And while doing a hydrodissection, make sure that you do not strip the corneal endothelium here. So this is another cataract which is quite denser than the one I showed you before. The density is the one which dictates the power and the technique of your phacoemulsification. It is always good to perform the vertical or the horizontal chop, because you are going to use less amount of phaco power in an already compromised endothelium, which could be much safer. Divide the nucleus as much as possible into smaller fragments, because when you're going to bring these larger fragments into the anterior chamber, which is already shallow, you could have an endothelial touch which could compromise the clarity of the endothelium later on. So divide the nuclear fragment as small as possible, and then bring them in the iris plane and then emulsify. Always use the coercive viscoelastics to protect the endothelium. And once this is done, always make sure you aspirate all the cortex. Here you have put a scleral tunnel, so the ballowing of the conjunctiva is quite common. Use a 26 gauge cannula to take the fluid outside. And I told you earlier, make sure that you inject the IOL right into the bag, avoiding endothelial touch. Aspirate all the coercive viscoelastic in the anterior chamber because you do not want to incite a postoperative graft rejections. Softer cataracts can be sometimes be challenging. They are not only hard cataracts are always difficult, softer cataracts can also be difficult. Sometimes these softer cataracts do not divide easily. So in these cases, when you have a cheese wiring happening as shown here, try to reduce the size of the nucleus by gradually emulsifying the periphery, decrease the circumference of these nucleus, and finally you can just flip these nucleus into the chamber or in the iris plane and then emulsify them quite easily. So softer cataracts can also be difficult. So the take-home message is that irrespective of the cataract densities, you always be careful whenever you do a phaco in a post-keratoplastic case, and inject the IOL right inside the bag, and always take care of the endothelium. Thank you.